This is the second chapter in our series on the circulatory system. In this chapter, we'll take a look at the heart, both its anatomy, its relationship to blood and blood vessels, and the physiology of how it works. Some ancient scholars surmised that the heart was a pump for blood, though Aristotle, taking a step backward, actually saw it as the seat of emotion. Today we're more conscious of our heart than we are of most of our other organs, and even more wary of its failure. In the 13th century, the coronary blood vessels were described as something that nourished the heart. 16th century, with Vesalius, he greatly improved the knowledge of cardiovascular anatomy and the study of the heart, and even the treatment of its disorders, which today is called cardiology. In the 20th century, we've made discoveries like nitroglycerin, digitalis, the ability to do coronary bypass surgeries and valve replacements and many other things. And cardiology is one of today's most dramatic attention-getting fields in medicine. In our first section, we'll be looking at an overview of the cardiovascular system. Our objectives are to be able to define and distinguish the pulmonary and systemic circuits of circulation, to describe the general location, size, and shape of the heart, and to describe something called the pericardial sac that actually encloses the heart. Again, we learned last chapter the cardiovascular system describes the heart and the blood vessels, whereas the circulatory system also includes the blood, which was the topic of last chapter. Again, in this chapter, we'll look specifically at the heart, and in our final chapter on the circulatory system next, we'll do the blood vessels. There's two major divisions of circulation. First, there's the pulmonary circuit. This generally happens on the right side of the heart. Blood comes into the heart on the right side from the body and goes through the right side of the heart and actually exits the heart to go to the lungs for gas exchange, which is releasing carbon dioxide to the lungs and taking in oxygen through diffusion. Then it takes a trip back to the heart onto the left side, which is called the systemic circuit. Blood goes through the left side and then is actually pumped out to the rest of the body, must make its way to all of the smallest of the capillaries in the body, all the way down even to your toes, and then back up to the right side of the heart again, where then it will start pulmonary circulation all over again. The left side of the heart has fully oxygenated blood because it just got rejuvenated from the lungs. And this rejuvenated blood is sent to the rest of the body via the aorta. Whereas the right side of the heart is termed as having oxygen poor blood because that blood has been to every part of the body. There's still oxygen in there, but it's oxygen poor, and it'll come back to the right side of the heart where it will get pumped to the lungs to have the gas exchange happen. When blood enters the right side of the heart, it enters from the top and the bottom of the body via the vena cava. Now, in many of the diagrams, you may see the colors red and blue to symbolize oxygen-rich and oxygen-poor blood. The heart is located in an area between the lungs called the mediastinum. This area here, labeled on the diagram, is called the base of the heart, whereas the tapered inferior end here is called the apex of the heart. In an adult, it weighs about 10 ounces, and at any age is about the size of a fist. Your notes will have some different diagrams of pictures of the heart and vessels. In these pictures, we can see the shadow of the heart, and we can see a portion of it poking out, a shadow over here, and the rest of it over there. The heart isn't just sitting in your chest cavity all by itself. It's actually enclosed in a sac, a double-walled sac, actually, called the pericardium. This allows the heart to beat without friction and provides room for it to expand, yet resists extensive expansion. And it's actually anchored to the diaphragm inferiorly and to the sternum anteriorly. If you remember from last semester for Anatomy and Physiology 1, we talked about serous membranes, which is the type of membrane the pericardium is made out of. They have both a parietal and a visceral layer. The parietal layer is up against the body cavity wall, and the visceral layer itself is up against the organ. Then between, there's a pericardial cavity, and there's some pericardial fluid that's secreted in there by the tissues. It kind of looks like this. If you had a water balloon and you punched your fist into the water balloon, it would make the two layers like this. Part of the balloon would border your hand, and the other part would border the body wall, and in between there would be fluid. Here in this diagram we can see the layers as well. In this section we'll look at the gross anatomy of the heart. When we're done, we should be able to describe the three layers of the heart wall. Identify the four chambers of the heart, identify the surface features of the heart and correlate them with the internal four-chambered anatomy, identify the four valves of the heart, be able to trace the flow of blood through the heart, and explain why the heart actually needs its own circulation. The heart wall has three layers, and they're named similarly to how we name the layers of muscle and nervous tissue, the same prefixes. So there's the epicardium, the myocardium, and the endocardium. The epicardium is also called the visceral pericardium. It's the one on the outside. This serous membrane covers the heart and has often adipose or fat in thick layers in some places. And the coronary blood vessels travel through this layer. Coronary referring to heart blood vessels that would actually serve the heart muscle itself. The endocardium is the smooth inner lining of the heart and the blood vessels, endo meaning innermost, and this covers the valve surface and is continuous with the endothelium of the blood vessels. And then there's the myocardium. This is the muscle tissue itself, the cardiac muscle. And the amount would be proportional to the workload. And the design of it, we can see in the picture over here, actually spirals around the heart, creating this spiral-like appearance, which is going to be important for the way it works and how the single muscle cells contract and actually squeeze the blood from the bottom of the heart on up to squeeze it out the top. There's also a fibrous skeleton of the heart made up of the proteins collagen and elastin fibers. These proteins provide structural support and also for electrical insulation between the atria and the ventricles because we want those pumping at separate times. Here we can see those layers. The endocardium, the innermost layer, myocardium, the muscle tissue in the middle, and then the epicardium on the outside, and the pericardial sac, and again that picture to show serous membrane with the fist punching into a water balloon. The heart has 4 chambers. There's 2 atria and 2 ventricles. We call them right and left. The 2 superior chambers are atria. The inferior chambers are the ventricles. The atria receive blood coming from the rest of the body, and also are the auricle seen on the surface to enlarge the chamber. Shown here in this picture, we can see the right auricle sticking out, enlarging the chamber here. Oh, over here, the left auricle. The right and left ventricles, their job is to pump blood into the arteries. When the atria pump, they only have to pump it to the ventricles, but when the ventricles pump, they have to get it out either to the lungs or to the rest of the body. There's also sulci, similar to when we talked about that word with the brain anatomy. When you see these labeled here, you can see they contain the coronary arteries. The heart actually has to have arteries and veins itself because it is a muscle, and muscle tissue, it's like any other tissue in the body, needs to have oxygen so that it can do cell respiration and do work, and then needs also those vessels to get rid of waste as well. In the middle, there's a interatrial septum. That's the wall that separates the atria, and an interventricular septum, which is the muscular wall that separates the ventricles. That wall will be important in terms of contraction later on when we talk about that. So I'll go back to this picture. Here's the interatrial septum here, and the interventricular septum here. Your book shows some different pictures, posterior and anterior views of the heart, which every picture you look at in different textbooks, you have to kind of look out because they could be different, and in order to get good views of things, sometimes they over-exaggerate, move them to different positions so they show up in the picture, like sometimes drawing the valves or the aorta so you can see it better. But if we know the general plan, then we should be able to be all right and get our bearings from any picture that we're faced with. Then there's the valves. Valves are always associated with ventricles. They ensure the one-way flow of blood through the heart. There's a lot of names for some of these valves. The atrioventricular valves, also known as the AV valves, control blood flow from the atria to the ventricles. And there's a right AV valve and a left AV valve, and these two go by some different names. The right AV valve has 3 cusps, so often it's called the tricuspid valve. And the left AV valve has 2 cusps, and was often called the bicuspid valve, and sometimes also goes by mitral valve. One of the ways I remember it is by my mnemonic lab rat. If I say lab, I can say the left atrium has the bicuspid valve, and then for rat, R-A-T, the right atrium has the tricuspid valve. That's always helped me remember where tricuspid and bicuspid are. But if you go by right AV and left AV, then that's a little easier to get. There's the chordae tendineae, and these are cords that connect the AV valves to what's called the papillary muscles on the floors of the ventricles. This prevents our AV valves from opening backwards or from prolapsing and allowing backflow of blood. We don't want that. So I'd like to go back a few pictures here so we can look at those. All right, so here is the papillary muscles we just talked about. They stick upward and then attach to these chordae tendineae, which are the string-like structures. If you find these when you're doing a dissection of a heart, just follow the strings upward and you'll find then the valve up here. Here's the tricuspid valve, or the right AV valve. And then over on this side, the left AV valve, or the mitral valve, or the bicuspid valve, whatever you want to call it there. And then, of course, the chambers, right atrium, left atrium, right ventricle, and left ventricle. Keep in mind when you're looking at it, it's actually backwards from what your right and left is, but your right and left doesn't matter. It's the patient that matters. The other valves are called the semilunar valves, and these are the valves that control the flow into the big arteries like the aorta, which would be coming off of the left ventricle, and the pulmonary artery, or the pulmonary artery that comes off the right ventricle. So I will back up once again to our picture of the heart. And the semilunar valves are right here. Here's the one that is entering pulmonary circulation. See how they're kind of half moon shaped, hence the name semilunar. And this one would actually be behind it, but here's an example of distorting the image and kind of bringing it forward so you can get at least a little bit of a look at it. So there's the left semilunar valve, or the aortic valve. Doing a incision in this plane, we're actually able to see those valves. Yes, you can actually see how these line up, and one is actually behind the other. And you can see the three cusps on the tricuspid valve here, and the two on the bicuspid or mitral valve. Here we can see the chordae tendineae and the papillary muscle. So let's look at blood flow through the chambers. Blood flow is regulated by pressure. When the ventricles relax, pressure drops inside those ventricles. I always have a saying that low pressure sucks. It helps me remember that. So whenever there's an area of low pressure, it sucks things toward it. And so pressure drops. That means blood is going to want to flow into that area of low pressure down a pressure gradient from high to low. So the ventricles relax, pressure drops inside the ventricles, The semilunar valves close as the blood attempts to back up into the ventricles from the vessels. But as long as those semilunar valves stay closed, it can't happen. The AV valves will then open, and then blood will flow from the atria to the ventricles. When the ventricles contract, the AV valves close, and yes, blood would attempt to back up into the atria, but those valves are closed, and if they're working properly, they don't allow it. Then the pressure rises inside the ventricles. And that's good, because if we have high pressure in the ventricles during contraction, that means that there's going to be lower pressure outside of the ventricles, and that blood is going to want to flow from the ventricles out into the vessels. And they'll do that when the semilunar valves open. And then blood can flow into either the aorta on the left side or on the right side, the pulmonary artery. So again, blood pathway travels from the right atrium through the pulmonary circuit. Remember, it's got to do a little side trip to the lungs, come back to the left side of the heart, and then do the systemic circuit, and then do it all over again. So these numbers here give us an idea of the order that blood flows through. If you were a red blood cell traveling through this heart, what order of everything would you go through? You'd enter here. We started in the right atrium. Blood came from the body. Then we would go through the right AV valve, or the tricuspid valve, down into the right ventricle. We'd be squeezed up into the right semilunar valve. We'd enter the pulmonary artery to go to the lungs. We'd do our gas exchange there. And then when we come back, we're going to come back via the left pulmonary veins. Then we're going to enter the left atrium, all fresh and oxygenated. Go through the left AV valve, or bicuspid or mitral valve, to the left ventricle. Then we'll be squeezed up and out. We can hardly see it back behind here. They just show it in the drawing. Squeezed out the left semilunar valve into the aorta, and then out to the body, and go into our systemic circulation, ending up coming back up when we have traveled through. Might take about a minute to the vena cava, the superior and the inferior, all the way back again to the right atrium to do it all over again. As we're looking at the heart here, also take a look at the muscularity. The chambers themselves are about the same size, but the muscularity is different. The pumping action of the left side has to actually get the blood out further to the systemic circulation, so the left side, left ventricle, has to be very muscular. Right ventricle doesn't have to pump as far, just to the lungs, so it's a little less muscular than the other ventricle. 5% of the blood pumped by the heart is pumped to the heart itself through the coronary circulation. That's the network of blood vessels that serve all of the myocardial tissue of the heart. That heart pumping action takes oxygen and nutrients and removal of waste, just like any other tissue of the body. And we can see that by these big vessels like the great cardiac vein. That's shown right here. The sulci that actually have these big vessels here. When muscles, or when cardiac muscle does not have what it needs with oxygen, if there's a blockage somewhere, that's called a myocardial infarction, sometimes also called an MI or just a plain heart attack. That's the interruption of the blood supply to the heart from a blood clot or a fatty deposit called an atheroma. This can cause death of cardiac cells in minutes. The heart does have some built-in protection from MIs provided by arterial anastomoses, which provide alternative routes for blood flow. Flow of the coronary arteries is actually greatest when the heart relaxes because the contraction of the myocardium, the muscle tissue, compresses the coronary arteries and actually obstructs the blood flow for a brief part of a second. The opening of the aortic valve flap during ventricular systole, which means ventricles are pumping, covers those openings to the coronary arteries and it blocks the blood flow to them. But during ventricular diastole, that means when the ventricles are relaxing, the blood in the aorta surges back towards the heart and into the openings of the coronary arteries, and the myocardial tissue then can be fed its oxygen and nutrients. Angina pectoris is some chest pain from partial obstruction of coronary blood flow. Pain is caused by the ischemia of the cardiac muscle, and the obstruction partially blocks the blood flow, so those poor muscle cells have to shift to anaerobic fermentation, which then produces lactic acid when they need to make ATP, and then pain results because of that lactic acid. You've probably felt the results of lactic acid before when you've done an activity with your muscles that you haven't done in a while, and the next day or two you feel the pain. That means you were doing anaerobic fermentation, which is a less efficient way to make ATP than if you were doing it aerobically. The myocardial infarction, sudden death of the patch of the myocardia, could actually result. An atheroma is a blood clot or a fatty deposit. Often it obstructs the coronary arteries. And cardiac muscle downstream from that blockage can die. Often some of the telltale signs are heavy pressure or squeezing pain into the left arm. We've talked about referred pain in the past. But there are still some heart attacks that don't have any symptoms, painless heart attacks. And this could happen in the elderly, in diabetics, or could happen in anyone. And all in all, myocardial infarctions are responsible for about 27% of all deaths in the United States. In this section, we're going to take a look at the cardiac muscle and the cardiac conduction system, so how the actual contractions happen. When we're done, our objectives are to be able to describe the unique structural and metabolic characteristics of cardiac muscle, to explain the nature and the functional significance of the intercellular junctions between cardiac muscle cells, describe the heart's pacemaker and the internal electrical conduction system, and to describe the nerve supply to the heart and explain its role. Here's where some previous chapters are going to help us out. Back from Anatomy and Physiology 1, when you discuss cells and how they can be connected and communicate with one another. And also when we talked about the nervous system and how action potentials happen. Muscle cells are called cardiocytes. They are striated, short and thick and branched. They have one central nucleus surrounded by light-staining masses of glycogen. The repair of the damage of cardiac muscle is almost entirely by scarring, also called fibrosis. Unfortunately, these types of cells do not regenerate like other types of cells do, and they don't go through mitosis. They have the intercalated discs, which join the cardiocytes end to end with three features: interdigitating folds, mechanical junctions, and electrical junctions. The interdigitating folds interlock with each other and then increase the surface area of contact. The mechanical junctions tightly join the cardiocytes together using a fascia adherens, which is a broad band in which the actin of the thin myofilaments is anchored to the plasma membrane. And then each cell is linked to the next via transmembrane proteins. They act like connectors. Then they have desmosomes, which are mechanical linkages that prevent contracting cardiocytes from being pulled apart from each other. Then they also have electrical junctions. I like to call them gap junctions, which allow ions to flow between the cells, meaning the cardiocytes can stimulate their neighbors. So like with a skeletal muscle, when you stimulated it, each one had to have its nerve. But with cardiocytes, you only have to stimulate one of them, and then that can be transferred through those gap junctions to all the neighbors, and then to the next neighbors, and then more and more after that, until you get every single cell stimulated and the whole heart muscle contracts. Cardiac muscle depends almost exclusively on aerobic respiration in order to make its ATP. They're rich in myoglobin and glycogen. They have huge mitochondria, which fill about 25% of the cell. That's where cellular respiration and making of ATP occurs. They're adaptable, though, to different organic fuels. Different fuels can be used to make ATP, whereas the brain had to have glucose. These guys can have fatty acids, amino acids, lactic acid, so on and so forth. Their main vulnerability actually comes more down to the oxygen deficiency than to lack of specific fuels. They're fatigue resistant because it makes little use of anaerobic fermentation or oxygen mechanisms. They don't fatigue for your whole lifetime. So the conduction system, this is how we're going to transmit an action potential to contract the whole heart, what coordinates the heartbeat. So it's composed of an internal pacemaker and then nerve-like conduction pathways through the myocardium. The heart generates and conducts rhythmic electrical signals in the following order. You could say it has an intrinsic control mechanism built in, autorhythmic cells. So first there's the sinoatrial node, also called the SA node. This consists of modified cardiocytes. The pacemaker initiates each heartbeat and determines the heart rate. And the pacemaker is in the right atrium just near the base of the superior vena cava. And this is going to spread the signal throughout the whole atria and allow it to contract before the ventricles do. Then we've got to make sure that the ventricles can contract. So there's the AV node, or the atrioventricular node. This is located near the right AV valve at the lower end of the interatrial septum. So this is our electrical gateway to the ventricles. So our impulse is going to travel to this area, and actually one of its jobs is to slow the impulse just a little bit. We don't want the whole heart contracting at once. We want the atria to contract first, give time for that blood to get out of the atria down into the ventricles. Then we want the ventricles to contract. Then the signal is going to move down the atrioventricular bundle, or the AV bundle, and it used to be called the bundle of His. The bundle forks into the right and the left bundle branches, and then the bundle branches pass through the interventricular septum towards the apex of the heart, down to the bottom of the heart. Then there's these Purkinje fibers. Those are nerve-like processes that spread throughout the ventricular myocardium. Remember, those cardiocytes then pass the signal from cell to cell through gap junctions. This diagram shows that with the numbers. Here's that SA node, or the pacemaker. The excitation spreads through the atriomyocardium. That's the arrows here. Then to number 3, here's the AV node. Down the interventricular septum, called the AV bundle. Here's the apex of the heart down here. We're going to run into these Purkinje fibers, which will transmit that signal to the rest of the ventricles. Remember the autonomic nervous system? Well, the heart itself pumps on its own, but it can be influenced by other sources in the body, including the sympathetic nervous system, which speeds it up. Their fibers terminate in the SA and the AV nodes. And then the parasympathetic nervous system slows the heart rate down with that vagus nerve traveling from the medulla oblongata down to the fibers of the SA node and the AV node, with little or no vagal stimulation of the actual myocardium itself. And again, this can slow the heart rate. In this section, we'll look at the electrical and contractile activity of the heart. Our expected learning outcomes or objectives are to explain why the SA node fires spontaneously and rhythmically, explain how the SA node excites the myocardium, so it contracts, describe the unusual action potentials of the cardiac muscle and relate them to the contractile behavior of the heart, and then be able to interpret a normal electrocardiogram. So when we say systole, we mean contraction, and when we say diastole, we mean relaxation. In fact, often when we say these words, it can refer to atria or ventricles, but oftentimes they usually refer to the action of the ventricles, such as when we read blood pressures, we put the systolic number on top. That's actually the pressure during the contraction of the ventricles. And the diastolic pressure goes on the bottom. That's the bottom number. And that refers to when the ventricles are relaxed. Normal heartbeat is called sinus rhythm. Remember, it's controlled by the sinoatrial node, or SA node, typically between about 70 to 80 beats per minute. That's also called vagal tone. If the sinoatrial node is damaged, then your heart rate would be set by the AV node, which doesn't beat as fast. If left alone, the SA node would want to go about 100 per minute. But if that's knocked out and we're left with the AV node, then your heart would beat 50 times a minute. AV bundle a little less at 35, and the Purkinje fibers at 30. If we were left with 50 beats a minute, we would have to give up exercising. That probably would not be good. The SA node does not have a stable resting membrane potential. It starts at negative 60 megavolts or millivolts and then drifts upward due to slow sodium inflow. It actually leaks sodium in. Gradual depolarization then occurs. That's called pacemaker potential. When it reaches threshold of about negative 40 millivolts, the voltage-gated fast calcium and sodium channels open, which then makes faster depolarization, bringing the charge up to about 0 millivolts. At that point, potassium channels open and then potassium leaves the cell. Remember, that's called repolarization. And once the potassium channels close, the pacemaker potential starts all over again. When the SA node fires, it sets off the heartbeat. As the internal pacemaker, it typically fires more than once a second, setting a usual resting rate of about 75 beats per minute. Here's a diagram showing that. In the beginning here we have sodium leaking in, depolarizes, and we get threshold right here. We get faster depolarization. The calcium and sodium leaks in faster. Our peak here. We get our, basically, remember, this is action potential here. Then the fast potassium channels open, rush out of the cell. So repolarization happens. And it'll start all over again. So, but the difference with the heart versus the nerve action potentials is that we're also using calcium to rush in during our action potential. We're not just using sodium and potassium, we're actually using calcium as well. And we have our slow sodium leak to begin with, whereas a nerve cell would need to be stimulated in order to activate any of the channels. In this case, the sodium just naturally leaks out, which acts as the stimulus. So the signal from the SA node stimulates the two atria to contract almost simultaneously. The signal then slows down through the AV node. Remember, the AV node's job was to actually slow down that signal. We don't want the whole heart pumping at the same time. So this area has fewer gap junctions, which then helps to delay that signal. Only 100 milliseconds though. This gives the ventricles time to fill up with blood. And then the signals, once they get down through the AV bundle and the Purkinje fibers, they transfer very fast. So the entire ventricular myocardium depolarizes and contracts in near unison. And the signals will reach those papillary muscles inside those chambers slightly later than the rest of the myocardium, though. The ventricular systole, or pumping, progresses up the apex of the heart. That spiral arrangement, which is important in that squeezing action to squeeze that blood out of the top of the heart. So the cardiocytes have a stable resting potential of negative 90 millivolts, and then they depolarize only when stimulated. So there's three phases to this: depolarization, plateau, and repolarization. The depolarization phase is very brief, and the stimulus opens the voltage-gated sodium gates, so the sodium rushes in, the membrane depolarizes, then the action potential peaks at about positive 30 millivolts, and those sodium gates close quickly. So that's all a lot like in the nervous system there. But the plateau phase is different. This lasts from 200 to 250 milliseconds, which sustains the contraction for expulsion of blood from the heart. So during this, the voltage-gated slow calcium channels open, emitting calcium, which triggers the opening of calcium channels on the sarcoplasmic reticulum, inside those muscle cells. Then the calcium binds to the troponin proteins, which triggers the contractions. Then the repolarization phase, the calcium channels close, potassium channels open, we get the rapid diffusion out of the cell to return it to its normal resting potential. There's a long absolute refractory period of about 250 milliseconds. This is different than compared to skeletal muscle. We don't want our heart to go into tetanus. We want to give the heart time to relax. Relaxing means that chambers can fill up with blood, so that repolarization has a plateau for a little while before getting back to threshold, and the ability to re-stimulate isn't there for a while. So basically, for our plateau stage, our potassium channels don't open as fast as they would in skeletal muscle. So these mechanisms are intrinsic, they're built in. Again, our heart needs time to have a relaxation period, even if it is for just a few parts of a second, so that blood can fill up into the chambers. There's that plateau. Measuring the electrical activity of a heart is done with an electrocardiogram, sometimes called in the past an EKG, but they seem to be calling it an ECG more and more, although I think EKG is easier to say. We put electrodes on the skin surface and we're able to record the electrical activity of the heart. So we should be able to take a look at an ECG and see if it's normal or not, and we should see a pattern that looks like this. So there should be a P wave. Right here we see that. This is when the SA node fires. The atria depolarize and contract, and the atrial systole begins 100 milliseconds after the SA signal. Then here is the QRS complex. This is during ventricular depolarization. The complex shape and spike is due to the different thickness and shape of the two ventricles. Then there's the ST segment here. This is when the ventricles are in systole and corresponds to the plateau in the myocardial action potential. The T wave, this is when ventricular repolarization and relaxation occurs. So again, in summary, the P wave is depolarization of the atria. The QRS to the RP here is depolarization of the ventricles. And the T wave is repolarization of the ventricles. We can see also between here and here is where the atria contract, and here to here where the ventricles have contracted. There can be deviations. If we look at the top one here, this is a normal EKG. This one is typical of a pattern called ventricular fibrillation. Ventricular fibrillation is called an arrhythmia when things are not normal. The electrical signals are random, it's chaotic, and during this, the heart doesn't get time to relax, to fill with blood, it doesn't get to pump blood. So it's the hallmark of a heart attack, and if it's not stopped, it can kill a person. one of the ways to help is to defibrillate. This is a strong electrical shock to the heart, which actually the intent is to depolarize the entire myocardium and stop it, and then give the SA node time to take over to reset the normal sinus rhythm. It's not a cure, but it'll give time for other corrective actions. This one's called heart block. It's the failure of the conduction system to conduct. Here we can see some P waves, but not every one generates a ventricular contraction. In this section, we're going to look at blood flow, heart sounds, and the cardiac cycle. So, our objectives are to explain why blood pressure is expressed in millimeters of mercury, describe how changes in blood pressure operate the heart valves, explain what causes the sounds of the heartbeat, describe in detail one complete cycle of a heart contraction and relaxation, and to relate the events of the cardiac cycle to the volume of blood entering and leaving the heart. The cardiac cycle is one complete contraction and relaxation of all four chambers of the heart. So questions to consider: how does the pressure affect the blood flow, and how are the sounds produced? So again, when we think of blood flow, we have to think of pressure. That blood flows kind of like water from high to low. And also I gave you the little hint earlier. Think about low pressure. Low pressure sucks. It sucks things towards it. That also happens in air as well. It's the same premise of why airplanes stay in the air and why race cars stay on the track, because low pressure sucks. Many items want to move from high to low. So we need a pressure difference or a pressure gradient. So actually we could say in the ventricles, at sometimes they have the highest pressure of the heart, but then at other times they also have the lowest pressure, because we need that in order to ensure that blood flows. Pressure is measured in millimeters of mercury with a sphygmomanometer, if you can say that real fast. So if we think of the events occurring on the left side of the heart, when the ventricle relaxes and expands, its internal pressure falls. If the bicuspid valve is open, then blood flows into the left ventricle. When the ventricle contracts, internal pressure rises. AV valves close and the aortic valve is pushed open, and then blood flows into the aorta from the left ventricle. So the opening and the closing of the valves are governed by these pressure changes. Just like you open a window or two in the house and you have other doors in the house and they might slam shut because of those pressure changes. Valves can sometimes not work properly. That's called valvular insufficiency. Any failure of a valve to prevent the reflux or the backward flow of blood is a valvular insufficiency. So valvular stenosis is when the cuffs are stiffened and the opening is constricted due to scar tissue. This could happen due to a disease called rheumatic fever or self-autoimmune attack on any of the valves, or when the heart overworks and becomes enlarged. A heart murmur is abnormal heart sounds produced by the regurgitation or the backward flow of blood through incompetent valves. Or mitral valve prolapse. That's the insufficiency in which one or both mitral valve cusps bulge up into the atria during ventricular contraction. That's actually hereditary in about 1 out of 40 people. It can actually cause some chest pain and shortness of breath. For the heart sounds, that's called Auscultation, that's the listening to the sounds made by the body, including the heart. When listening, you should hear a lub, first of all. That's actually the AV valve slamming shut. The second sound, a little softer but sharper, is called the dup. That's actually the semilunar valves of the ventricle shutting. In young children, it's not often unheard of to hear a third sound, but if it's heard in adults, then it's usually because of something wrong. So the phases of cardiac cycle is ventricular filling, that's during diastole. They fill up when they're relaxed. Isovolumetric contraction is during systole. Ventricular ejection during systole, pushing the blood out. Isovolumetric relaxation during diastole. And then the entire cardiac cycle, all of these phases, is completed in less than a second, all to do it all over again. So with the ventricular filling, the ventricles expand. When they expand, their pressure drops. We create an area of lower pressure. Remember, low pressure sucks. When the AV valves open, blood is going to flow from higher pressure up in the atria down into the ventricles where there's lower pressure. In these three phases, rapid ventricular filling, diastasis, which is slower filling. The P wave of an electrocardiogram occurs at the end of diastasis. And then atrial systole, or contraction, is the final 1/3. So the end diastolic volume achieved in each ventricle is about 130 milliliters of blood. Then there's the isovolumetric contraction. This is when the atria repolarize and relax, and then remain in diastole or relaxation for the rest of the cardiac cycle. So the ventricles depolarize, that's that QRS complex. They begin to contract. The AV valves close as the ventricular blood surges back against those cusps. But if our valves are working right, then we won't get any backflow. Here's where we'd hear that first sound, the S1 sound, with the slamming of those AV valves shut. It's isovolumetric because although the ventricles contract, they don't eject blood. Pressures in the aorta and the pulmonary trunk are still greater than those in the ventricles. So the cardiocytes exert force, but with all four valves closed, the blood cannot go anywhere. Then we have ventricular ejection. This begins with the ventricular pressure exceeding the arterial pressure. With all this contraction going on, we've created a high pressure zone. Blood wants to flow from high to low. So the pressure peaks at about 120 millimeters of mercury and 25 millimeters of mercury in the right, first one being in the left. Then we have rapid ejection where the blood spurts out of the ventricles quickly, and then reduced ejection with a little slower flow, a little lower pressure there. Only about 200 to 250 microseconds, and this corresponds to the plateau phase of the cardiac action potential. Creates that T wave of an EKG. The stroke volume, the output, is about 70 milliliters here. Notice that the ejection fraction is about 54%. We don't actually expel it all. There still might be 60 milliliters of blood left in the ventricles. Then the isovolumetric relaxation, this is that T wave on the EKG. The ventricles begin to expand. The blood from the aorta and the pulmonary trunk briefly flows backward, filling the cusps, and then closing those semilunar valves. That creates pressure rebound, and it appears as what's called a dicrotic notch in a graph of arterial pressure. It's that blood kind of slamming backwards on those valves, but the valves are closed, so it can't go through. Here we would hear the dup, the second sound, and it's isovolumetric because the semilunar valves are closed and the AV valves have not yet opened. So therefore the ventricles are taking in no more blood. So when the AV valves open, ventricular filling begins again. In a resting person, arterial systoles last about 0.1 seconds, ventricular systole about 0.3, and the quiescent period when all four chambers are in diastole is about 0.4 seconds. So the total duration of a cardiac cycle is about 0.8 of a second in a heart that's beating 75 times a minute. This is a neat chart because we can compare all of those things all in one, from the EKG to the sounds that are being made to the pressure and the amount of blood. So again, the volume changes here. If the end had 60 milliliters left in the ventricles, then what's passively added during atrial diastole is 30 milliliters. And then when the atria contract at 40 milliliters, then the end diastolic volume is 130 milliliters. The stroke volume ejected by ventricular systolar contraction, 70, which then leaves us back to 60 again. Both ventricles must eject the same amount of blood. So normally they do. Right and left sides eject the same amount. That's the Frank-Starling law of the heart. Congestive heart failure results from the failure to do so, to eject blood efficiently, usually because of a weakened heart or other problems. If we were to get blood backing up into the lungs, that would cause pulmonary edema, fluid building up. If it backed up on the right ventricular failure, then we would get systemic edema. And of course then could lead to total heart failure. In this last section, our expected objectives are to define cardiac output, explain its importance, identify the factors that govern cardiac output, discuss some of the nervous and chemical factors that alter heart rate, stroke volume, and cardiac output, explain how the right and left ventricles achieve balanced output, and describe some effects of exercise on cardiac output. Cardiac output is the amount ejected by the heart by each ventricle in 1 minute. You can measure it by heart rate times stroke volume. It's about 4 to 6 liters per minute at rest. And a red blood cell, if you could follow it through the body, would take about a minute before it would arrive back to the heart. Cardiac reserve is the difference between a person's maximum and resting cardiac output. As you become more fit, that number increases. As you become sick or lack of exercise, couch potato, it decreases. Your heart rate, so again, cardiac output is heart rate times stroke volume, so we'll look at both. So heart rate can be measured with your pulse, which is the surge of pressure produced by each heartbeat that stretches your arteries, and you can feel that by palpating it. Infants have a really high heart rate, 120 beats per minute. Females have a little bit higher than males and adults, and as you get older, it rises even more. seems like as your heart gets less and less efficient, it beats faster in order to compensate for that. So some clinical terms: tachycardia is when your heart goes too fast, and bradycardia is when it goes too slow. So there's positive and negative chronotropic effects on heart rate. Chronotropic refers to anything that adjusts the heart rate. So positive would speed it up, negative would slow it down. Remember, the heartbeat is intrinsic. The heart controls its own beat. It has its own ability to contract, but it does have many influences, including the autonomic nervous system. So the sympathetic, remember, can speed it up, can release norepinephrine to do that. That actually affects the calcium channels, and it increases the calcium inflow, so it accelerates things, and that's how it actually speeds it up. Whereas with the parasympathetic nervous system, it uses acetylcholine to bind to muscarinic receptors, and this has an influence on the calcium gates. It causes, as calcium leaves the cell, they become hyperpolarized and then fire less frequency and slows down the heart. Other inputs in the cardiac centers in the medulla oblongata are diverse. Could be due to your higher brain centers, your cerebral cortex, your limbic system, hypothalamus, sensory or emotional stimuli, like you're walking in the woods and you see a bear. Obviously, that stimuli is going to cause your heart rate to go faster. Then there's the proprioceptors, sometimes also called proprioceptors. We've talked about that there's the muscle spindle, the Golgi tendon organs. There's the joint kinesthetic receptors. Those are kind of neat because as soon as you start to exercise, they tell the cardio center that you're actually moving and that you're going to need an increased heart rate before you need it. With baroreceptors, just like barometric pressure, think pressure. Those are receptors that measure pressure. Chemoreceptors respond to chemicals like oxygen and carbon dioxide. And then near the heart itself, the carotid sinus and the aortic arch also have receptors for all of this. And all of these can influence heart rate. There's other chemicals like nicotine and caffeine that can influence heart rate as well. There's the autonomic neurotransmitters, norepinephrine and acetylcholine, the adrenal hormones, norepinephrine and epinephrine. Those are cardiac stimulants, like the fight or flight response. Nicotine has an effect on those. Thyroid hormone can increase the number of receptors to the heart. And caffeine can inhibit the cAMP breakdown and can prolong the adrenergic effect. Electrolytes like potassium and calcium can have an effect. Using these words here, hyper means too much and hypo means not enough. So having too much potassium, excess potassium would then diffuse into the cardiocytes. The myocardium would become less excitable and the heart rate would slow down. Could become irregular as well. With not enough potassium, the cells can be hyperpolarized and then would therefore require increased stimulation. With calcium, you could have too much and could decrease the heart rate and the contraction strength, and then vice versa if there's not enough calcium. The other factor of cardiac output is stroke volume. That's the amount of blood pushed out. Remember, the ventricles eject almost as much blood as they receive. That's the Frank Starling law of the heart. So the proprioceptors signal the cardiac center at the beginning of exercise that lets the heart know it's going to need an increased rate. Those come from the joints and the muscles. So the increases in the heart rate and the stroke volume can cause an increase in cardiac output. Some of your best athletes, you may notice that they have a really low heart rate, but that's okay because they're actually they have a hypertrophic heart. Their heart is more efficient with each pump. They're putting out more blood. It's doing it much more efficiently. But if you're sedentary and have a low heart rate, that's a different story. Coronary artery disease can be one problem associated with this. That's a constriction of the coronary arteries, usually a result of stuff building up in the arteries of the heart. That's called atherosclerosis. It's an accumulation of lipid deposits that degrade the arterial wall and then obstruct the lumen. This can begin with some damage, usually caused by, over time, hypertension and diabetes or other problems, disease, and then that inflammation transforms into the atheroma, that clot, and then can become hardened into a complicated plaque. And that's one cause of arteriosclerosis.